We are not getting that this. So we just interrupt her, or we raise
You
our
interrupt
hand.
her. You can interrupt. No issues. You can do
Okay.
as you do a case presentation in the department.
Yeah.
Same way.
Okay.
Exactly same way.
Okay.
Okay, ma'am.
Ma'am, we are live.
Okay. So good evening, everyone, and I welcome everybody to this episode of Thyroid Clinics. And as usual, we will be discussing a case to start with, and then we will be going ahead with one talk and quiz for the students. So before we start, this is a short introduction of the Indian Thyroid Society.
तस्य भासय सर्वमिदं विभाति.
So this is our Thyroid Clinics team. So I, with Dr. Roma, coordinate the sessions. And we have our president who is guiding us, Dr. Krishnan Shadri, and secretary, Dr. Arun Menon, and treasurer, Dr. Mini Pillai. And we have other team members as well, Dr. Chitra, Dr. Reddy, and Dr. Gandhi with us, who manage the whole show. So we all welcome you to submit your research to Thyroid Research and Practice. And this is our official journal of the Indian Thyroid Society. And you can scan this QR code to fill this form, and the journal is online, and you can submit your research online to this journal, and any of your thyroid articles or any research concerning thyroid can be submitted to this journal. And we welcome you all, the faculty, we welcome to become a reviewer for Thyroid Research and Practice. We need more reviewers to work for the society for this journal, because we have lots and lots of articles coming, and we want peer review, and we want review from the reviewers. So any faculty who is interested can please scan this and fill the form and can become a reviewer with our journal. So this is today's the Thyroid Clinics episode, and then today we will be discussing one case. And I welcome the moderators, Dr. Ankush Desai and Dr. Aditi Chopra, for today's case discussion. Dr. Ankush Desai is professor and head Department of Endocrinology at Goa Medical College, and he is interested in diabetes mellitus as well as thyroid, and he has around 40 research publications to his credit. And we also have Dr. Aditi Chopra today with us. She is a consultant endocrinologist at Manipal Hospitals, Bengaluru. And she also has multiple achievements, including publications in major journals, as well as research grants from Endocrine Society of India and travel grant from the Endocrine Fellows Forum, ASBMI. So we have a senior resident who will be presenting the case. Her name is Dr. Shruti, and she is the senior resident at Department of Endocrinology, Goa Medical College. So she'll be taking us through the case. So I hand it over to the moderators for today, Dr. Ankush and Dr. Aditi, to carry forward with the session.
Thank you so much, madam. Sir, we'll ask Dr. Shruti to...
Yeah. Please, start.
Yeah.
Good evening, everyone. We have a 34-year-old female who's a not known case of any illness prior, presented to us in April 2024 with complaints of weight loss of about 15 kgs over 6 months, oligomenorrhea of 45 to 60 days cycle since the onset of menarche, which has worsened since 6 months, but the details of the evaluation and treatment were not available. Patient also complained of increased appetite and stool frequency of about 3 to 4 times per day, heat intolerance, excessive sweating, tremors of the hands, irritability, intermittent palpitations, and dyspnea on exertion for 3 months. Patient also complains of noticing neck swelling, which was more apparent after weight loss for 3 months, but it was not associated with any compressive symptoms. There was no history suggestive of pain, redness, watering in the eyes, blurring of vision, diplopia or lid swelling. No history suggestive of thickened skin or redness over the lower limbs, especially over the shin of the foot. There was no history suggestive of changes in the nails. No history of fever or neck pain, exposure to iodine in the form of betadine gargles or radiological contrast. No history suggestive of any systemic autoimmunity in the form of photosensitivity, malar rash, oral ulcers, joint pain, swelling, hair loss, dry eyes, dry mouth. And there was no history suggested of any autoimmunity running in the family.
Anything in the history of the eyes that you can ask? Anything more? You have taken a detailed history suggestive of inflammation, but any other history that you take in patients? Anything like bulging or protrusion of the eyes or inability to close the eyes? Yeah, so that also you can take.
Yeah. So there was no significant past history. There was no history suggestive of smoking in the patient. And regarding the menstrual history, patient had a 45 to 60 days cycle since the onset of menarche, which was irregular, 4 to 5 days duration with a decreased flow. So on examination, height of the patient was 146 centimeter, weight of 58 kgs, BMI was 27.2 kg per meter square, pulse rate of 120 beats per minute, which was regular, normal volume, no radioradial or radiofemoral delay, and blood pressure was 140 by 90 millimeters of mercury in the right arm, supine position. There was no pallor, icterus, cyanosis, clubbing, lymphadenopathy, or pedal edema, but fine tremors were noted on outstretched hands. And neck examination revealed a grade 1 goiter, which was more on the right compared to the left, with the isthmus enlarged, soft in consistency, nodular surface. It was non-tender and no bruit was heard. And there was no thyroid-associated ophthalmopathy, dermopathy, or acropathy at this time of presentation. And the Venn score was 32, which was suggestive of toxicosis. This was the initial presentation of the patient, which was in April 2024. Even though clinically we couldn't have any eye symptoms, but apparently the picture shows there was slightly a more prominent right eye when compared to the left eye. Systemic examination was within the normal limits, except for the tachycardia, and there was no heart murmurs noted. So according to indications, it
Shruti,
showed elevated free and
wait,
total
Shruti, 1 minute.
hormone. Yes, sir.
Shruti, 1 minute. So,
Yes, sir.
what is your impression or your opinion at the end of this clinical examination after history examination?
So, so this patient is basically presenting with signs and symptoms which are suggestive of thyrotoxicosis. So, at the end of history and examination, my first differential diagnosis would be probable thyrotoxicosis, probably Graves' disease, or it could be a long-standing multinodular goiter. So.
There isn't much history of goiter.
If there was no, sorry.
Okay.
So according to the thyroid function test, it was showing elevated total and free hormones with suppressed TSH and elevated T3 to T4 ratio of more than 20, going more in favor of primary hyperthyroidism with elevated serum TSH receptor antibody levels, which was confirming now the primary hyperthyroidism. And the technician 99 thyroid scan was suggestive for diffuse toxic goiter with an increased tracer uptake of about 9.5%, which was more on the right side of about 5.9% compared to the left side. And ultrasound was suggestive of a mildly enlarged gland, lobulated contour, heterogeneous echo texture with a few subcentimetric lymph nodes in the right lobe.
Do you need an ultrasound? Do you routinely do ultrasound for
no, ma'am. This was
evaluation of
this was done prior to the this was done prior to the
because I think thyroid functions and a technician cannot trap antibodies.
Yes. This was done prior to the technician. So investigation wise, the baseline HbA1c was 5.9%, which is suggestive of a pre-diabetic range, and the liver function tests were within normal limits, and lipid profile was also within the normal limits. So a diagnosis of primary hyperthyroidism, Graves' disease without clinical TAO was made, and patient was initiated on antithyroidals, that is carbimazole at 30 milligrams per day in 3 divided doses. 3 months later, in July 2024, patient presented to the Department of Ophthalmology with the complaints of redness, watering, foreign body sensation, which was initially treated with the lubricants, and patient improved symptomatically. However, patient still complained of intermittent symptoms. This was the initial presentation in July 2024, wherein we can see that there was slight prominence in the left eye with some amount of lid retraction. And 5 months later, in December 2024, patient presented to our OPD with the worsening of the eye complaints, which were more in the right side compared to the left side, with protrusion of both the eyes for 2 months, which was gradually in onset and progressive in nature, gritty sensation in both the eyes, pain on movement of the eyes, especially in the upward and the lateral gaze, which was there for 2 weeks, and redness, watering, and photophobia for 2 weeks. Also associated with blurring of vision in both the eyes, difficulty in closing the right eye, and bilateral lid swelling, which was there for 1 week. And the subsequent image is of December 2024, wherein, sorry for the bad image, but the symptoms which the patient compared was more on the right side, where we can see there is hyperemia and there is conjunctival chemosis, which is more in the right side compared to the left eye. The left sclera and the conjunctiva comparatively appears clear in compared to the right side. But there was no complaint. This was the corresponding thyroid function test, wherein the dose of carbimazole was titrated according to the T4, FT4 levels, but the TSH still remains suppressed. history suggestive of spontaneous pain in the eye, retrobulbar pain, or diplopia. On examination, the ocular findings in the July 24 and December 2024 are tabulated, wherein the visual acuity was slightly reduced in the right eye. The near vision, color vision, and the visual fields remained within the normal limits. And Hertz exophthalmometer showed the evidence of proptosis in December 2024. And CAS scoring at the initial presentation in July 24.
What would you
the left side
consider
was
as
1/7,
significant,
whereas
Dr. Shruti? What would be the cutoff
yeah.
for proptosis?
Actually, the standard proptosis cutoff which is given for the Asians is 16 and 17 millimeters in the women and men. But for the Indian scenario, we take a cutoff of more than 20 millimeters as significant. So the corresponding CAS score in July 2024 and December 24 is as tabulated. That was non-significant in July 24, whereas the CAS score in the right eye in December 24 was 5/7, which was indicating an active disease. And the severity was moderate to severe. There was no sight-threatening GO, but lid retraction of more than 2 millimeters was present. There was moderate soft tissue involvement. Exophthalmos was noted, and there was no diplopia. However, in the left eye, we noticed a mild GO. This was the same image of December 2024. The VISA score was also suggestive of an active disease with a score of 16 out of 20. So investigation-wise, MRI now
Why
showed
do you
enlarged muscle bellies with
monitor
tender.
this? Why do you measure severity and activity? Why both? And what is the significance of each one of these things separately? What does activity tell you? Basically, it tells you the inflammation.
The activity tells about the initial inflammatory period, and severity tells about the outcomes of the inflammation. It could be in the form of excessive proptosis, or it could be because of the upcoming fibrosis, which is there. So that tells us, the severity tells us, gives the information about that phase.
Right. So
The
more
later
of a
phase.
structural or a
Structural
functional sort
damage
of
to
a
the
disability
that.
from the severity score is what
severity
you
score.
get.
Yeah. MRI was suggestive of enlarged muscle bellies with tendons being spayed, and hyperintensities of the muscle bellies were noted on T2 weighted imaging, and fat stranding was seen in both the orbits, and proptosis seen bilaterally, which was more on the right side compared to the left. These are the MRI images of the patient. And the muscle thickness of individual muscles have been tabulated with the normal reference range. So in our patient, there was more involvement of the superior rectus and the lateral rectus compared to the inferior rectus, which is more commonly known to be.
Which are the more commonly involved muscles?
To start with, it's the levator palpebrae superior, followed by inferior rectus, followed by medial rectus, and superior rectus and the lateral rectus.
And would you do a MRI? I mean, what was the reason for doing a imaging in this case? Do we do
actually the
MRI for all our Graves or vitopathy patients?
No. Usually the indication for the MRI is mainly to if it is a sight-threatening GO in such conditions, and in some very severe cases to assess for the severity, they prefer doing MRI.
Right. So maybe in your case there was a decline in the vision, and the score was 5/7. So what exactly would you want to see in the MRI when you're looking for a sight-threatening or a dysthyroid optic neuropathy in the MRI?
One is the narrowing at the orbital apex, orbital narrowing, and also the compression of the optic nerve, the extension of the optic nerve.
Crowding at the apex, which is compressing the optic nerve. And what do you prefer, MRI or CT? What imaging do you prefer, MRI or CT?
Basically, to know the activity and severity, MR is preferred because the soft tissue details are more prevalent on MR. And if at all the patient has to be considered for the surgery, then CT is a better option.
Yes, right. Because it gives you a more better bony window. Yeah.
So the diagnosis of primary thyroid. To summarize, we have a 34-year female who had presented with the overt symptoms of thyrotoxicosis, which was confirmed on the investigations and initiated on antithyroidals. Later, 8 months later, she had presented to us with a florid eye symptoms, which are more apparent on the right side compared to the left side. And so diagnosis of moderate to severe active Graves' disease is made.
You should say, Shruti, one small thing. You should say moderate to severe Graves' ophthalmopathy on the right side, and mild.
With the mild,
it appeared, I think so, inactive. No, mild, inactive.
Yes, sir. It was mild on the left side.
Yeah, you should sort of, differentiate for the sake of our audience, so they don't know that you are dealing with one eye separately and, telling it accordingly.
Yeah. Okay.
Yeah.
It was more severe, moderate to severe on the right compared to the left. Left showed mild GO. Patient underwent lateral tarsorrhaphy in the right eye since they were suspecting a sight-threatening kind of GO in the right side. So they had started with the 1 gram per day of intravenous methylprednisolone, which was started in December, which was given for 3 days, followed by once the patient showed improvement in the soft tissue involvement, then they started the regimen of moderate to severe Graves' orbitopathy, which is 500 milligram IV once a week for 6 weeks, followed by 250 milligram of IV once a week for another 6 weeks. So a total cumulative dose of 7.25 grams of methylprednisolone was received.
Right. So what would be your upper limit of a total cumulative dose?
Ma'am, it shouldn't go more than 8 grams per cycle. That's upper limit. So the follow-up CAS score in March 2025 in the right eye was 6/10, and in the left eye was 5/10, which was still indicating an active disease. So any score more than 4/10 in the 10-pointer CAS is indicative of an active disease. This was the recent image of patient in March 2025. And the current ocular findings showed a slight improvement in the visual acuity. And the Hertels was still suggestive of increased proptosis.
The proptosis had worsened, is it? It was 20.
Yes, ma'am.
22,
It was
I think.
22 and 20. Yes.
Hmm.
Which had worsened.
So overall, Shruti, if you just sort of now you have got the
Yes, sir.
entire view till March 2025. So do you
Yes, sir.
think that the steroids have helped the patient really well, or you think it's been not really, taken up, responded well, or you think that things have worsened really?
So actually, initially when we had given her the dose of 1 gram, the loading dose of 1 gram, patient had actually shown improvement by about 50% in the soft tissue changes. So we were feeling that there was improvement when she had shown the initial reports, and after receiving a cumulative dose of 7.25, there were some amount of soft tissue involvement which is seen, but not to a level we expected it to happen. But maybe when we look at this table of TFTs which have been tabulated here, the TSH actually remained suppressed throughout, and there was development of hypothyroidism subsequently. And in between, patient had also lost to follow-up for few days, and there was non-compliance with the patient's part as well. So in December 24, when she had presented with the florid symptoms, there was some amount of rise in the free hormonal levels. So that could be one factor.
Shruti, so what you want to say is that the patient did not respond to steroids very well, and this is because of the hypothyroidism, because patient did not take the medicines well, because the disease was not managed by the doctors very well, in the sense they should have thought of. So what would have been your approach if you had wanted to treat this, literally
Actually,
with
the
your knowledge?
current UGOGO guidelines of 2021 suggest to use a mycophenolate mofetil as mycophenolate sodium or mofetil as the agent, which is along with the IV steroids, which is not a practice in our ophthalmology department. So it was given only the IV steroids were considered in this patient. So maybe that is one factor which could have been gone wrong. And the other thing which has been contributed by the patient side is the missing the follow-ups regularly, and also missing medications. And the TSH not being in the euthyroid stage could also be one of the component in this.
Okay, so now just one question there is, if in hindsight, now we are at March 2025, and you have a patient with these Hertels of 26 and 22, and you have that the patient is having 6/9, 6/6, what would you do now for the ophthalmopathy? You have given 7.25 or something grams of steroids.
So maybe we would wait for the patient to achieve euthyroidism first, to look for the improvement in the symptoms first. If at all, if she's not responding, then we consider the second line management or another cycle of high dose of steroids probably.
The second line management that you have
What
in
are
your
the
mind, and all the
options? Yeah.
So the second line management includes a high dose of steroids, starting with a cumulative dose of 7.5 grams. We can start with 500 milligrams of IV steroids per week for 6 weeks, followed by 250 milligram, giving a cumulative dose of 7.5 grams, or a dose of oral steroids along with azathioprine or cyclosporin, or orbital radiotherapy with a dose of 20 grapes per orbit, which is given at 2 grapes per day over 10 days in a 2 weeks period, or 1 gram per week over 20 weeks, which is a slow tolerated dose. Or there is another new, meaning a drug which is approved in 2020 by FDA, that is teprotumumab, which is a IGF-1 receptor antagonist. That is another drug which could be used in this patient, which can be given at a dose of 10 milligrams per kg to start with as a first dose, followed by increment to 20 milligram per kg, which is subsequently given at 3 weekly interval for about 8 doses. And other options would be use of rituximab, which is an anti-CD20 monoclonal antibody, and tocilizumab, which is a monoclonal antibody against the interleukin-6. So all these are the second line options which we can use.
Right, I think.
Okay, go ahead.
Yeah, so maybe orbital radiotherapy is one thing, or maybe using something like rituximab or some of the second line drugs.
Yep.
And how about managing the thyroid now? What would you do? So you've reduced the dose of carbimazole.
Yeah. So currently the patient, recently we had reduced the dose of carbimazole to 5 milligrams per day. So we are awaiting the report in the coming days. So based on that, we would want to titrate the dose and then try to achieve euthyroidism.
So suppose she comes back to you in 2 months and she's probably with a TSH of 5 and she's on carbimazole 5, then what would you do for her? So she has taken total antithyroid drugs for a year now, right?
Yeah. So maybe if the soft tissue changes are still not improving, then it's better to consider for the second line management than for waiting at this point of time.
And her thyroid? What about how will you manage her thyroid? About her antithyroid drugs? You would want to continue antithyroid drugs for a longer time, for a longer duration?
Can be used up to 2 years.
Yeah, even longer,
No,
even longer than 2 years.
Yeah, Shruti, the question is just to see the thyroid function test. If someone is remaining hypothyroid, then it is not worthwhile continuing. Otherwise, it is worthwhile to continue it.
Yeah.
And is there a role of doing a TRAB antibodies?
Yes, ma'am. Because
you've done one at baseline.
Yeah, one we had done at the baseline. So the TRAB antibodies could tell us about the severity of the disease as it correlates positively with the thyroid ophthalmopathy.
So what are the risk factors for anybody having a severe thyroid eye disease? Does your patient have any of those risk factors?
Yeah, in our patient, the one thing which we have noticed is the TFTs being not in the euthyroid state. So that is one risk factor. So other risk factors mainly include smoking and older age, male gender, and hypercholesterolemia, and elevated TSH receptor antibody levels, which we have seen.
Right.
And so other contributing factors could be uncontrolled diabetes and the other factors.
Yeah. Go ahead.
So coming to the assessment of Graves' ophthalmopathy, we have a clinical activity score wherein there is a 7-pointer system when the patient is seen first, and we also have a 10-pointer scoring, which is over time we assess to know the response to the treatment. So the 7-pointer system mainly has 1 point to each, including pain, redness, and swelling. Mainly the pain or pain on the upward, sideward, or downward gaze, redness of the eyelids or the conjunctiva, and swelling of the eyelids, caruncle, or plica, or chemosis. And the follow-up score, which includes 3 additional points, is the increase in proptosis by more than 2 millimeter in 1 to 3 months, decrease in more than 8 or equal to 8 degree in the eye muscle motility in the direction in 1 to 3 months, and decrease in the visual acuity of more than 1 line on the Snellers using the pinhole in 1 to 3 months. So at presentation, the scars of more than 3/7 is indicative of an active disease, and a follow-up scar of more than 4/10 is indicative of active disease. So classification of severity according to the Hugo, it classifies it into mild, moderate, and severe. Mild, moderate to severe, and sight-threatening GO. In mild GO, it doesn't hamper the day-to-day activity of the patient, but usually one or more of the following has to be present in the patient to it as mild. That includes minor lid retraction of less than 2 millimeter, mild soft tissue involvement. Exophthalmos is less than 3 millimeter above the normal for the race and gender, and there is no or intermittent diplopia. That is the diplopia which is seen on awakening, or it could be on the very tired eyes. And no corneal involvement, or the corneal involvement which responds to the lubricants. Moderate to severe GO is patients without any sight-threatening GO, but there is limitation to the and more than one of the following has to be present. That is lid retraction of more than equal to 2 millimeters, moderate to severe soft tissue involvement, and exophthalmos of more than 3 millimeter above the upper limit of the normal, and inconstant or constant diplopia. Inconstant is the one which is seen in the extremes of the gaze, and constant is the one which is seen at rest or at the primary position of the eye. And sight threatening or the very severe GO in patients with dysthyroid optic neuropathy. So how do we assess the soft tissue changes? First, coming to the eyelid swelling, in the mild eyelid swelling, the patients may be aware of the changed appearance. However, they do not fit into the criteria of moderate to severe eyelid swelling. So what does moderate eyelid swelling tell us? When there is a definite subcutaneous fluid or the skin thickening which is present, and when the patient looks down, when we see in the right hand side of the figure, when the patient tries to look down at 45 degrees, the skin fold in the central upper eyelid, it forms an angle, and the lower eyelid swelling does not form any festoon kind of thing in the moderate eyelid swelling. Whereas in severe, this angulation is lost and it becomes a more rounded structure, and there is formation of a festoon in the lower eyelid. So this was with respect to the eyelid swelling. When we move further, the eyelid erythema, there is no erythema, then we give it as a CAS negative. Definite erythema, either including the pretarsal or the preseptal, was given as a definite yes for the CAS positivity. Conjunctival redness, no redness, or mild equivocal redness is given a negative CAS. If it is a definitive redness, where is moderate, less than 50% of the involvement, excluding the plica and caruncle, and severe if it is more than or equal to 50% of the involvement of the plica or caruncle. Coming to the chemosis. So how do we assess a chemosis is by drawing an imaginary line. So patient adopts a primary gaze. We use a slit lamp which is located at 60 degrees, which is midway between the lateral canthus and the limbus. And the patient is assessed where the sclera and the conjunctiva separates. And there's an imaginary gray line which is drawn. And anything which is higher than of 1/3 of the height of this line, which can be seen as a dotted line here, which crosses more than 1/3, is considered as a chemosis, definitive chemosis. And other is a plical and caruncle inflammation, which is seen in the figure, that is given as a positive score. So coming to the treatment of Graves' ophthalmopathy, the general measures which we use is to avoid smoking and to avoid iatrogenic hypothyroidism. In case of mild GO, we give local treatment in the form of artificial tear drops for the dry eyes and ophthalmic gels or ointments, and the systemic adjunct therapy using selenium sodium, which is given at 200 micrograms per day for 6 months. And in moderate to severe GO, as we had already discussed, either a cumulative dose of 4.5 grams along with a mycophenolate mofetil for about 24 weeks, or a higher dose in the severe cases of about 7.5 grams, starting with 500 milligram followed by 750 milligram followed by 500 milligram can be given. If at all the patient goes into the inactive GO, wait for about 6 months and then a rehabilitation will be considered. In case the second line treatments, as I had already discussed, is mentioned here. And in case of very severe GO or dysthyroid optic neuropathy, IV methylprednisolone 1 gram over 3 consecutive days in the first week, followed by the same regimen for the second week. And we'll have to assess for the visual functions for the end of second week. If the visual functions improve, that means we can continue with the treatment as per moderate to severe GO. If at all there is no improvement, then urgent surgical decompression has to be considered. So what about the steroid prophylaxis in patients with receiving the radioactive ablation? So in mild active GO, with the absence of risk factors for GO deterioration, we considered using prednisone at the dose of 0.4 to 0.5 milligram per kg per day, which is started 1 to 3 days after the ablation, which is continued for 1 month and then tapered over 2 months. In case of patients who are treated at risk of progression, the risk mainly involves the smokers or severe or unstable hyperthyroidism or high serum TRAb antibodies. The regimen could be either a high risk, which is at a dose of 0.3 to 0.5 milligram per kg body weight as a starting dose, which is tapered over 3 months, or a low risk of 0.1 to 0.2. Or which is tapered over 6 weeks. If there's a long-standing inactive GO, in the absence of risk factors, then there is no need of using any steroids in these patients. So there are newer upcoming therapies which are mainly directed against the inflammatory markers. As we know that there is activation of the T helper cells, 1 Th1 cells initially, which releases the pro-inflammatory cytokines. The main drugs which are directed against are the interleukin 17A, that is vonukizumab and secukinumab. The next is the activation of the B cell, and monoclonal antibody which is directed against the B cell is a belimumab, which decreases the B cell population. Further activation of the T cells is also further activation of the pro-inflammatory cytokines is decreased. Next is the plasma cell, differentiation of B cell into plasma cell, which formation of immunoglobulin G antibodies, which are directed against the TSH receptors. So this is now inhibited by the use of batoclimab, which is a FC receptor, neonatal FC receptor inhibitor. So the recycling of the immunoglobulin by this drug is inhibited, so that there is no antibodies which are directed against the TSH receptor. So the other drugs are the drugs which are directed against TSH receptor. TSH receptor as well as the IGF-1 receptor. The known drug which we know is teprotumumab, which is the monoclonal antibody against the IGF-1 receptor, which is approved by the FDA in 2020. The others are the Viridin groups and K170, which is a blocker of TSH receptor. And there is one dual antagonist which is used, that is lisintinib, which is still in the phase 2 to 3 trial, which is antagonist against the IGF-1 receptor as well as the insulin receptor. So all these drugs are in that pipelines, which are mainly acting against the orbital fibroblasts, decreasing the adipogenesis, the differentiation into the myofibroblasts, and decrease hyaluron synthesis.
So, Shruti, just to,
Yes.
so that's all the last slide. That's great. Okay, just to say, how does ophthalmopathy trend in relation to thyrotoxicosis or in Graves' disease? How does it go? How does the ophthalmopathy go in the time sequence in relation to the thyroid disease or thyrotoxicosis?
Okay.
This is last, I'm just asking a couple of questions and finishing it.
Yeah. So the ophthalmopathy, it can be either before the diagnosis of Graves' disease, or it could be along at the time of the diagnosis, could be after the diagnosis. That is better, I think, explained with the Rundle's curve, which is a natural history of the Graves' ophthalmopathy, which is seen. Usually, I think it is within the 12 to 18 months of the diagnosis of Graves' disease, the ophthalmopathy is seen.
Okay, why do we get radioiodine induced thyroid means ophthalmopathy? Why does radioiodine increase the the development severity as well as the activity of the ophthalmopathy?
So that is
why
kind
does
of a
radioiodine cause?
Because of the increased inflammatory mediator release after the ablation.
So you get increased release of TSH receptors because there is a release of TSH receptor. There would be more chance of
TSH receptor antibodies.
Okay, now I think we are done with time. No, Aditi, you have any more questions? Because I can see 8:32 on my screen here.
Right. I think it was a very challenging case, but I hope we have. Usually we have patients who respond very well to IV glucocorticoids. Yes, there is a small fraction of our patients who don't respond. It's good that we have newer drugs, but I think still the most robust evidence and data is with IV glucocorticoids when it comes to managing patients with thyroid eye disease. I don't know, sir, if you have experience of using any other second-line drugs. We had one patient for whom we used rituximab, but not many patients for whom we've used the second-line drugs.
Yeah, so this is probably a patient where we could now, when I was talking here and we were discussing the case, we could consider rituximab primarily because the course has been short. If you remember the paper which was published by Salvino in 2020 or 2019, so those people who had a shorter duration of the hyperthyroidism, they responded better to rituximab than the ones who had a longer, like 1 to 2 years history of hyperthyroidism. So just might be a case. So let's see how it goes about once the euthyroidism is achieved. That's what I'm looking at. Yeah, I'm done.
Yeah.
Yes. Over to Pramila, ma'am. Thank you so much.
I don't think there are any questions in the chat box. So thanks, Dr. Ankush and Dr. Aditi and Shruti for the discussion and the case. So we move on to the next topic for today. That is the talk by Dr. MJ Paul, and he will be talking on toxic goiter. So we can have his introduction, please. So he is an endocrine surgeon from CMC Vellore. He is the former president of Indian Association of Endocrine Surgeons, 22. And he has more than 100 publications to his credit and many book chapters as well. So I welcome Dr. MJ Paul, and we'll have the talk for now, and then we will go on to the quiz after that.
Thank you very much. I hope you can hear me.
Yes, sir. Good evening, sir. Audible.
Okay.
We can hear.
And is the screen on? You able to see the screen now?
Yes, sir. Yes, sir.
Okay. Sure. So the topic is toxic, which brings the medical
Sir, make
fraternity
it slideshow now, sir.
Yeah, that better? Yeah. So toxic goiter, just to introduce, this is a patient I saw many years ago, and you can see that she has interestingly lower lid retraction and what looks like a nodular goiter. In fact, when we teach this to students, sometimes they ignore the eye signs and then say this is a toxic multinodular goiter. But in fact, it's a Graves' disease, and I bring this to you, one of the rare variants where you have a nodular Graves, as we call it. And this actually, she shared a picture kindly, which for teaching, shows her 5 years prior to this. She was on medical treatment for 5 years and had a slow deterioration in her body. You can see the weight loss, the eye changes, and the gland enlarging. So the ravages of this disease, when not managed appropriately, she was just kept on medical therapy for 5 years. So it's something that we need to think about when to intervene. I know some are out of our control, but this is the introduction to the main toxic goiter, which is Graves' disease. And these are the effects that we see. So just for the students, defining hyperthyroidism as being overproduction by the gland. And here we deal with the Graves' primary thyrotoxicosis, Plummer's disease or toxic multinodular goiter, and the toxic nodule or the AFTN, autonomously functioning toxic nodule as we call it now. Thyrotoxicosis, a condition where there is circulating excess hormone, which could be from exogenous administration or destructive release, sometimes seen in cases of thyroiditis. Historically, interestingly, the name was ascribed to Robert James Graves, who wrote the first lucid monograph on the topic and described it in detail. Although before him was Parry in 1786, who actually recognized this as exophthalmic goiter. And in mainland Europe, they still call it Basedow's disease in many countries, who is known in Europe for having described it. The second name associated is Henry Plummer from the Mayo Clinic, who first described toxic nodular goiter. It's also called Plummer's disease. Now, if we look at the common and rare causes of toxicity, the first three, which we went through, the diffuse toxic Graves, the toxic multinodular Plummers, and the toxic solitary or AFTN. And less common than those would be nodular goiter because of exogenous iodine administration leading to hyperthyroidism, and factitious or exogenous thyroid hormone excess or transient release by thyroiditis. Now, rare causes of toxicity would be diffuse thyroid autonomy, a metastatic thyroid carcinoma. Surgeons would have seen thyroid cancer metastasizing typically to bone, where they produce fleshy large masses which can secrete excess hormone, causing a toxic state. Then a struma ovary, where the ovarian teratoma contains thyroid tissue and can lead to toxicity. A pituitary tumor secreting excess TSH and stimulating excess hormone production. Choriocarcinoma or hydatiform mole, where HCG mimics TSH at high levels. Neonatal thyrotoxicosis, where the maternal antibodies cause the toxicosis in the neonate. Postpartum hyperthyroidism, also autoimmune etiology. And post-iodine therapy rarely can lead to a toxic state. So there's a whole list that can be remembered. Of course, you have to know what is common and what is rare. Now, if we look at the epidemiology, Graves, of course, is always described as a more common disease than Plummer's disease. And toxic nodular goiter is described in iodine sufficient populations as a 60 to 80% Graves versus only 10% plumber, and the rest being the rarer causes, including toxic nodules. Now, if you have iodine deficient populations, we can see these percentage sometimes can be changed. Of course, where large number of goiters are present over time, you will get many more higher percentage of toxic nodular goiter or plumber's disease. So why do we treat this? Because the natural history of toxic multinodular goiter involves the same chronic complications of thyrotoxicosis found in Graves. When untreated, patients may be at risk for atrial tachyarrhythmias, hypertrophic heart disease, and decreased bone mineral density and fracture risk. So this is the pathogenesis of Graves. You can see beta cells producing B cells producing immunoglobulins, and they stimulate the thyrotropin receptor, which leads to increased hormone circulation, as well as increase in T cell produced inflammatory cytokines, and therefore the deposition of glycosaminoglycans in eye disease as well as soft tissue. So interestingly, when we do the full spectrum, we now think of autoimmune disease as a spectrum. And if you check the so-called Hashimoto antibodies, they up to 30% of clinical Graves can exhibit raised values of the Hashimoto antibodies as well. And the reverse is also true. This is an interesting picture of the various mutations that actually have been documented and described in Graves' disease. You can see so many positions of the TSH receptor can be mutated and lead to disease in the individual. The activation and blockade are two aspects of TSH receptor antibodies. So you have activating antibodies causing or stimulating antibodies, as we call them, that cause the Graves' disease. And you have the blocking antibodies that can lead to primary hypothyroidism. So this picture describes well how the fit of the antibody on the receptor is what can lead to either stimulation or blockage. So either toxicity or hypothyroidism, both being on the autoimmune spectrum. Now, in the clinical presentation, we can have either marked or subtle symptoms. You can have exacerbations and remissions, as is known to happen in all autoimmune conditions. So we look for also associated autoimmune conditions. Up to 20% of patients can present with associated vitiligo, common rheumatoid arthritis, pernicious anemia, ITP, or Sjogren's syndrome. This is a typical case of a male presenting with eye signs, goiter, and he walks into your OPD with a mild tremor, is sweating, anxious, and fidgety. So this is sort of a walk-in diagnosis, but not all cases are so classic, and we have to deal with variations as well, especially when there's no ophthalmopathy. Then the easier way is to check the antibody, the TSH receptor antibody. Now, it has multi-system involvement, as we know. The goiter, Graves' disease involves goiter in 90%. And in the elderly, it's important to remember the goiter may not be so obvious. So when you cross 50, it drops down to 75%. And we have the condition called apathetic goiter, where an elderly person comes with weakness, weight loss, and even sometimes dysphagia, but no goiter, and they're actually a manifestation of Graves'. Eye disease, as was dealt with in the case very well, can occur 75% within a year of the goiter and hyperthyroidism. And the classifications, I mean, the eye disease signs, I think, are well known and can be read. I'll not go into these details. The old system of no specs classification has been replaced by clinical activity score. And now, of course, we have the modified clinical activity score, which has 7 points and can be simplified as 3 swellings, 2 redness, and 2 pains. Especially useful for surgeons to remember. And we remember that if it's 3 or more, we call it active disease, and a maximum score can be up to 7. Now, this is, we refer if you want to actually measure exophthalmos, you need to put on the exophthalmometer to do a very detailed assessment. But a simple way, which I use in the outpatient, can be just to use a scale from the outer canthus, that is the orbital ridge, which is just next to the outer canthus. And from the side, you can actually see how much the eye is protruding beyond the orbit. So 20 to 22 would be the range of upper limit of normal, and you can easily diagnose it through this simple scale test. So we see dermopathy in about 1 to 2%, and acropatchy, as shown in the fingertip thickening in the figures that are here. So the clinical features and biochemical confirmation is usually sufficient for diagnosis, and role of antibody testing is important now. When they present without exophthalmopathy, or there is a doubt about diagnosis, then TRAB is available now in most labs. Iodine uptake studies can be done, which showing more than 40% uptake of the radioactive iodine administered is diagnostic. This is a pathological gross and microscopic appearance of Graves. It just diffuse enlargement. You can see there's mild lobulation and nodularity can be seen in advanced cases. And the treatment approach is basically threefold with antithyroid drugs or other, as we said, modern drugs like rituximab or immunosuppressants, and between definitive therapies of total thyroidectomy or radioiodine ablation. Now, this treatment has proponents for and against. These are the for points and the against points. I'm not going into detail, but just from the surgical side, it's a quick, effective remedy with low recurrence, and you have to balance that against the risk of complications. Iodine therapy, as we know, you may need 1 to 2 doses. Single dose leads to only about 80% success on average. In the multinodular toxic nodular goiter, it has less effectiveness, and therefore, in our situation, most often we prefer surgical therapy. Antithyroid drugs are effective for quick remission, quick effect, and we can await remission in up to 30 to 40% in autoimmune thyroid disease like Graves. But long term, you have to worry about side effects, non-compliance, and relapse. So the treatment strategy is basically initial medical management with antithyroid drugs. You have pneumocozole plus and beta blockers. Up to 18 months awaiting remission. If unremitting, then we'll need definitive therapy, either ablation or surgery. And surgery is always total thyroidectomy to avoid recurrence. Some people use preoperative Lugol's iodine, but this is effective to reduce only in early disease. It's been shown that disease more than 6 months cannot be documented to actually reduce vascularity on studies using ultrasound with color imaging. So the treatment schedule, antithyroid drugs, titration is generally considered better than the block and replace strategy, but yeah, I'll take my medical colleagues' view on this. What about the impact on eye disease? Which treatment has better impact? So it is adverse effects on eye disease are seen more in radioactive iodine than the antithyroid drugs or surgery. So there are trials showing surgery versus RAI, and the trend is worsening eye disease in radioactive iodine. If the addition of steroids is used, then it lessens the risk in severe cases of worsening eye disease. So what is the role of adjunctive ATD also, antithyroid drugs? It's preferable to stop it prior to therapy and then restart it after therapy. And we've seen worldwide there's a difference in strategy. In Asia and Europe, antithyroid drugs is generally the first choice, whereas USA, where RA is easily available, the first choice is most often straight ablation upfront. So in a country like ours, we'd probably say start with antithyroid drugs. That's the policy we use at our institute. You have up to 40% chance of remission, and therefore you can avoid surgery or ablation. And a titrating course is preferred. Selective use of block and replace in certain conditions. So avoid RA and severe eye disease, use steroid prophylaxis, anticipate hypothyroidism post-therapy. You have to follow up that patient after iodine ablation, and use adjunctive ATD selectively, preferably stop before ablation. So the role of surgery we've seen is again more used in Asia and Europe than in the US. Advantages, as I said, rapid cure, avoids the risk, and histopathology is available. As we know, there's a higher risk of papillary cancer in this. So the indication absolute would be where the suspicious malignant nodule, sometimes called Lenhart syndrome, and compressive symptoms are there, or it's pregnancy with uncontrolled GD needing quick control, a relapse after 18 months of antithyroid drugs, or patient doesn't want radioactive iodine for fear of the radiation effects. And in pediatric patients also, where there is a increased chance of failure of antithyroid and increased cancer risk if there's a nodule. The relative indications are large goiter, severe eye disease, poor compliance, and the need for rapid control. So what is the role of iodine in pre-op preparation? It was a lot talked about using Lugol's or supersaturated potassium iodide solution through the Wolff-Chaikoff effect. But the effect, as I mentioned, is seen only in recent onset disease. It's been shown in Doppler studies that more chronic cases after 1 or 2 years, the effect is not that good. And in fact, in our establishment, we've stopped using it almost altogether in Graves. The extent of thyroidectomy should be total or near total, indicated where cancer is confirmed or suspected, severe ophthalmopathy, and patients unwilling for reoperation or RAI. So earlier there was a near total or subtotal strategy, but this has been shown that it is not useful. And a total thyroidectomy, what we call a approach of embryological approach, removing the pyramidal lobes, any accessory tissue that may be in the neck outside of the thyroid also must be carefully done by the surgeon. So this is about the subtotal historical view. I'll skip this in view of time. And some studies on surgical therapy, comparing subtotal versus Dunhill procedure or a total procedure to see what is the effect on eye disease. Here they found one study said equal. The second study, Abe group from Japan, showed that subtotal thyroidectomy had less effect on the eye than RAI. Therefore, this led to more usage of surgery in eye disease. A meta-analysis of total versus subtotal, another comparing two strategies of surgery, said the total thyroidectomy had 100% cure and subtotal led to hypothyroid, euthyroid, or recurrence in up to 8% when subtotal was done. So that is why generally it is not preferred now. So immunosuppressive therapy, it was presented by the previous talk, so I will skip that. So this is the autonomous thyroid disease, a toxic multinodular goiter or adenoma that develops, shows the slow development of thyroid autonomy that evolves in nodules that initially are scintigraphically not detectable, but are a clone of mutated thyroid epithelial cells, and slowly over time increase suppression of TSH leading to hyperthyroidism. Takes years or decades to happen. And this is an example of Plummer's disease. The picture below shows the uptake study, which shows hot areas, cold and warm. Here, the disease is not self-limiting. It cannot regress by itself or remit by itself, and is not very effective with radioiodine therapy. And the best option is surgery. And here also, total is definitely better than subtotal thyroidectomy. In solitary toxic nodules, or AFTNs as we call them, the most present as a single nodule. The risk of malignancy has to be assessed. The ATA classification said it's low risk, but in Indian studies, we have seen significant in our own experience, almost 10% malignancy risk. So you can do hemithyroidectomy if it's low risk tumor, or you can even give radioactive ablation, hoping that this nodule will ablate and the remaining thyroid which was suppressed will wake up and start functioning. Hashimoto thyroiditis can have transient toxicity, and this is very common now in our practice, especially in coastal areas. We're seeing almost like an epidemic of Hashimoto's, and you have to worry about coexisting triple pathology. We are seeing nodular hyperplasia or follicular nodular disease, as it's called now, with Hashimoto, and multifocal cancers is very common now. So these are antibody related. Eventually, most go into hypothyroidism. There's a small risk of a lymphoma long term. And surgery is indicated only a small minority when there's a suspicious nodule or an enlarging symptomatic goiter. So thank you from the Institute at Vellore. We are ready to take questions.
Can you please check if there are any questions?
Sure, ma'am. No, ma'am, there are no questions as of now.
So I think with this, Dr. M.J. Paul, thanks for the nice talk, and it was really like a lucid lecture which you gave on the toxic goiter. So I think we move on to the next session for today, that is the quiz. So I request Dr. Vijay Bhaskar Reddy to take over the proceedings for the next sessions.
Thank you, Dr. Pramila. Thank M.J. Paul sir for giving the elaborate monologue on toxic goiter. So we move on to the next much awaited quiz. So I'll start off with the quiz rules. To participate in the quiz, click on the button. There will be a small button, attend quiz button given on the screen, which is being live streamed. So the quiz will be conducted through a platform called Slido. So you're requested to use a laptop for ease of experience. Quiz will run for around 5 minutes. The quiz master will display a case or description of question by screen sharing a PowerPoint file. There will be 10 questions. Each question will be available only for 30 seconds with the timer on. So the faster you answer, the more marks you get. Kindly do not refresh the page or go back onto the page. So to conduct the quiz today, we have quiz master Dr. Sunetra Mondal. So Sunetra Mondal is Assistant Professor, Department of Endocrinology, NRS Medical College, Kolkata. She is won the Yuva Ratna Award from ESI 2023 for Best Research in Private Capacity. She is also awarded the A.V. Gandhi Award for Excellence in Endocrinology. She has 40 PubMed publications, and she's editor of a book on metabolic support. Over to you, Dr. Sunetra.
Thank you so much, sir.
Ma'am, can
Can I
you wait
start?
2 to 3 minutes, ma'am?
Yes.
Yes.
They'll have to wait for people to log on to the quiz platform.
Okay. Please let me know when I should start.
Sure.
The questions are quite straightforward, and if you have listened to today's case presentation carefully, students, then you can answer many of them. But of course, it's not just about knowing, as sir said, it's also about the fastest fingers first. So
You can start now.
okay. So what about the timer? Will it be shown on my screen too?
No, ma'am. I will tell you when to start next question.
Okay, okay. So I start with the first question. So what is the name of the measurement A plus B by C? This measurement, as you can see on this coronal MRI orbit image, what is the name of this measurement A plus B by C? Is it Barrett index, Nugent's index, Coca-Cola index, or Rundle index?
Next.
Next question. How many questions are there in the ThyPro questionnaire? 84, B20, C10, D40.
Next.
Which of the following is a low-risk thyroid neoplasm? Low-risk thyroid neoplasm. A. Hobnell variant papillary thyroid CA. B. Oncocytic carcinoma. C. Diffuse sclerosing papillary thyroid CA. And D. Hyalinizing trabecular thyroid tumor.
Next.
Question 4. Which of the following is a serious adverse effect of teprotumumab? Teprotumumab. A. Neuropathy. B. Hearing loss. C. Immunosuppression. D. Hyperglycemia.
Next.
Which is the target of the novel tyrosine kinase inhibitors larotrectinib and entrectinib? A. BRAF, VEGFR, C. NTRK, and D. RET. All of the following can help in the differentiation of RTH beta from TSH secreting adenoma, except all of the following can help in the differentiating RTH beta from TSHoma, except A. Positive family history. B. Exaggerated TSH response to TRH. C. Raised alpha subunit is to TSH molar ratio. And D. A normal pituitary seen on MRI.
Next.
Question number 7. During gestation, the total T4 increases by A. 5% per week from the 3rd week. B. 5% per week from week 5. C. 5% per week from week 7. D. 5% per week from week 14.
Next.
Question 8. Which thyromimetic has shown potential for neuroprotective effect against multiple sclerosis in animal models? A. Eproterom, B. Sobeterom, C. Resmetirom, D. DITPA.
Next.
Question 9. What percentage of Indian population is consuming adequately iodized salt as per the results of the recently conducted National Iodine Survey? A. More than 50%, B. More than 75%, C. More than 90%, D. 100%.
Next.
The last question for today. Children with medullary thyroid CA due to MEN2A high-risk RET mutation, which is the recommended age for total thyroidectomy in them? A. Within the first few months of life. B. At or before 5 years of age. C. When serum calcitonin starts to rise. D. After 18 years of age. MEN2A high-risk RET mutation. I guess the question should have been they have a mutation, they don't have MTC, but what is the age for prophylactic thyroidectomy in them?
Completed.
Okay. I should stop?
Yes.
Thank you, Dr. Sunetra, for having taken through the quiz. So we will discuss the answers to the DM quiz first, and meanwhile the tech team will get the quiz winners list ready. So you can start discussing the answers for the DM quiz.
It's not shared. Are my slides visible?
Yes, yes.
So regarding the first question, it was very obvious. So this is the Barrett index, one of the many other soft tissue signs of dysthyroid optic neuropathy that we see on MRI, including others like orbital fat prolapse, perineural fat effacement, enlarged lacrimal gland. There are some bony signs also like increased angle of the orbital apex. And there is, of course, the stretch neuropathy seen by taut nerve in the sagittal image. So, of course, Coca-Cola sign, as we know, is because of the muscle belly thickening with tendon sparing seen on eggshell scan, and bundles is not an index, but the curve, we already discussed it during case discussion today, which shows the disease progression of tau in relation to Graves. And the Nugent's index is the degree of effacement of perineural fat. So the correct answer for that was Barrett index, and the usual cutoff considered is 67% in Asians. Coming to the next question, how many questions are there in the ThyPro questionnaire? As you all know, the ThyPro questionnaire is a questionnaire for measuring quality of life for benign patients with benign thyroid diseases. And there are 84 items summarized in 13 scales, along with an additional question for overall quality of life. And each item is rated on a 0 to 4 scale. So the correct answer was 84. Coming to question number 3, which of the following is a low-risk thyroid neoplasm?
So as we know, the correct answer is hyalinizing trabecular thyroid tumor. So if you look at the WHO classification of thyroid neoplasm, the more recent one released in 2022, which had some changes from the 2017 one. And because it focused on identifying separately some of the low-risk neoplasms like NIFTP, follicular thyroid tumor of uncertain malignant potential, and also hyalinizing trabecular thyroid tumor. And if you go through this TRP article on a critical appraisal of the WHO 2022, there is very clear table differentiating how this is different from the 2017 WHO classification, including all of these. So I suggest you go through this article. Regarding the next question, a serious adverse effect of teprotumumab, because hyperglycemia and hearing loss both can occur, but hyperglycemia is usually reversible. But hearing problems can be irreversible and more serious. And others are muscle cramps, alopecia, dysgeusia, and reactivation of IBD. Regarding the fifth question, which is the target of larotrectinib and entrectinib. So the correct answer was NTRK. So we know the tyrosine kinase inhibitors, the approved one currently in use as soda, lenvatinib for PTC and Bande and cabozantinib for MTC. But we have a host of novel TKIs nowadays against more selective molecules in the pathway, like selpercatinib and pralsetinib, again the red PTC, larotrectinib and entrectinib against NTRK, and BRAF inhibitors like the dabrafenib and vemurafenib, and MEK inhibitors like trametinib, selumetinib, etc. And today is the era of more systemic therapies for radioiodine refractory advanced thyroid carcinoma, and these are the approved agents as of now. So entrectinib and larotrectinib are approved for NTRK positive radioiodine refractory advanced DTC, and these are NTRK inhibitors. Coming to question 6, all of the following can help in differentiating RTH beta from TSH-OMA except, because the correct answer was raised alpha is to TSH molar ratio. The raised ratio we expect in TSH-OMA, not in RTH beta. And the other options were very obvious: a positive family history, normal pituitary, and exaggerated TSH response to TRH are seen in RTH beta, not in TSH-OMA. During gestation, this was again a question directly from TRP. All of us know this. You can go through this wonderful article. So we know it starts to rise because of the HCG. It starts to T4 starts to rise from the 7th week of gestation by around 5% per week between 7th to 16th week. After, so that by the week 16, there is around 50% rise in total T4 above the pre-pregnancy level. Coming to question 8, which thyromimetic has shown potential for neuroprotective effects against multiple sclerosis in animal models? So we are discussing a lot about resmetirom in NASH nowadays. But again, this was a direct question from a TRP article on thyromimetics, and which have discussed the other available thyromimetics as well, which have been tried in different situations. And sobetirome and its prodrug SOB-AIM2, which crosses the blood-brain barrier and within the CNS gets converted to sobetirome. So these in animal models have shown potential neuroprotective effect against multiple sclerosis. Coming to question number 9, what percentage of Indian population is consuming adequately iodized salt as per the National Iodine Survey? So the correct answer was more than 75%. So again, the TRP, this article has very nicely discussed the results of the National Iodine Survey, which was conducted in 2018-2019 over more than 25,000 households across the different states. And they saw that 92% were consuming iodized salt, but 76.3% was consuming adequately iodized salt, that is with a ppm more than 15, iodine, more than equals to 15. Coming to the last question, so children with MEN2A high risk red germline mutation, which is the recommended age for prophylactic thyroidectomy. So the correct answer was at or before 5 years of age. So as we know, regarding the MTC risk level, so MEN2B, M918 exon 16 mutation, it is always highest risk. MEN2A due to 634 mutation is high risk, and MEN2B due to 883 mutation is high risk. Rest of them are considered moderate risk. So if we look at the ATA recommendations for prophylactic thyroidectomy for those children having red germline mutation, So men to be highest risk, this is within the first few months of life, that is 918, exon 16 mutation. Men 2A, high risk mutations, the recommended age is at or before 5 years of age. And for men 2A, moderate risk mutations, rare mutations, the thyroidectomy total is to be performed when the calcitonin starts to rise. So that was the end of the DM students' questions.
Thank you, Dr. Sunetra, for having gone through the answers. Tech team, we have the results ready for the quiz.
Yes, sir.
Yes. Can you share the results? The first we will have the results for today's quiz.
So for today's quiz, just allow us 4 to 5 minutes. We'll get that.
Okay, so we'll get back. I think we'll discuss the answers to the practitioner's quiz, which was conducted online, and then we'll come back to the results of both the quiz together.
Okay, sir. So coming to the answers of the practitioner's quiz. So the first question was Hirata syndrome refers to. So the correct answer was autoimmune hypoglycemia following methimazole ingestion. So we know insulin autoimmune syndrome, autoimmune hypoglycemia due to insulin autoimmune syndrome can be seen after many medications. Common ones, but the most common ones are methimazole and carbimazole, as also alpha lipoic acid. And there are certain markers of diagnosing it using, including very high levels of insulin, extremely high level, more in 600, in more than 500. And ratio of insulin C-peptide ratio is usually more than 1 in this syndrome. And there could be other autoimmune diseases. And very important factor is the history of recent use of a drug which could cause it. Next question was, which statement is false regarding Hürthle cell carcinoma? So the correct answer here was a lesser likelihood of regional lymph node metastasis as compared to follicular carcinoma. So as we now know, Hürthle cell carcinoma is an aggressive type of differentiated thyroid carcinoma seen more commonly in the elderly population, have a more likely to have a history of radiation exposure, is usually multifocal, bilateral, with a high chances of regional as well as distant metastasis as compared to follicular carcinoma and many other types of carcinoma. Very high mortality rates if it is metastatic, up to 80%. And most of these tumors are radio resistant. They have a very low radioiodine uptake and do not respond well to radioiodine therapy. The next question was a very straightforward one. Neck pain is classically not seen in which of the following thyroiditis? So as we know, postpartum thyroiditis is classically known as the painless or silent thyroiditis, and neck pain is not seen. It can be seen in all the other types, subacute post-viral thyroiditis, acute pyogenic, or even radiation-induced thyroiditis. The next question was, which of the following does not help to differentiate between amiodarone-induced thyroiditis type 1 versus type 2? And again, the correct answers was ratio of T3 to T4. So as we know, amiodarone-induced thyrotoxicosis type 1 versus type 2, there are, although there is a lot of overlap, but there are ways to differentiate between these two because the basic pathogenesis is different. AIT type 2 is mostly a destructive type of thyroiditis, and AIT type 1 is mostly seen in those having a pre-existing maybe autoimmune or other thyroid disease. It usually occurs soon after starting amiodarone, whereas type 2 occurs long after. So the radioiodine uptake is lower is expected to be suppressed in AIT type 2. And the Doppler also should show lower vascularity in AIT type 2. And the treatment is also, the preferred treatment is antithyroid drugs for type 1 and steroids for type 2, glucocorticoids for type 2. And but the T3, T4 ratio, which can be used to differentiate thyroiditis from other forms of thyrotoxicosis, is hyperthyroidism is not helpful in this case because of amiodarone also inhibits the D2 enzyme, D2 deiodinase enzyme. So this ratio is not helpful in differentiating AIT type 1 from type 2. Next question was, which of the following medication increases TBG? So the correct answer was tamoxifen. So thyroxine binding globulin can be increased by oral estrogen, ACRMs like tamoxifen, and some other agents as well, whereas androgens and glucocorticoids decrease TBG. So endogenous thyroid hormone production usually increases and compensates for this change in TBG, but if the patient is on exogenous levothyroxine, there could be an increased dose requirement after initiating oral estrogen or tamoxifen, but there is no such effect seen with transdermal estradiol. Next question was, which of the following conditions does not increase the risk for gestational thyrotoxicosis? So again, the correct answer was very straightforward. It was threatened abortion. So we know gestational thyrotoxicosis occurs because of increased HCG level. In a threatened abortion, we expect lower levels of HCG and not higher levels, and therefore it is not likely to cause gestational thyrotoxicosis. The next question is, which of the following nodule is suitable for radiofrequency ablation? And the correct answer here was a non-functioning solitary nodule, TIRADS2. So as we know, a radiofrequency ablation is increasingly being recognized as a first-line treatment strategy for managing symptoms in non-functional and benign thyroid nodules for improving the quality of life by addressing cosmetic and symptomatic concerns of the patient. And the ideal nodule is a well-defined solitary nodule which is non-functioning and also proven benign by FNA, at least 2 benign FNA or 1 benign and a classically benign FNA and a classically benign ultrasound findings. Cystic nodules which are less than 10 ml are the best ones to respond. The next question was on strain ratio, which is an index used to differentiate benign from malignant thyroid nodules. So which investigation modality is used to measure the strain ratio? And again, the correct answer here was the thyroid elastography, D. This is the direct question from the TRP journal. Showing the from this article showing the utility of ultrasound elastography in differentiating benign from malignant thyroid nodules, and the authors have suggested a cutoff value of strain ratio around 3.8, having good sensitivity and specificity to differentiate benign from malignant thyroid nodules. So ultrasound elastography is the modality we use to measure strain ratio. Question number 9 was again from the recent India iodine survey. So the Indian state with the lowest consumption of iodized salt, and quite shockingly, the answer was not any of the sub-Himalayan states or the northeastern states. It was actually Tamil Nadu. And so household coverage was of adequately iodized salt of more than = to 15 ppm was lowest in Tamil Nadu, followed by Andhra Pradesh. And coming to the last question, so which of the following type of calcification gets the highest score in the ACR TIDAD system that is suggestive of greatest suspicion of malignancy? So again, this was directly from the TRP journal, which very nicely gave a pictorial description of the ACR TIDAD system. The correct answer was punctate echogenic foci. So this article, this is the pictorial description. So as we know, cometal artifacts gets 0 point, macro 1 point, peripheral or rim calcifications gets 2 points, and punctate echogenic foci gets the highest value, that is 3 points with regards to the ACR TIDAD score. Thank you so much.
Thank you, Dr. Sunetra, for going through the answers for both the quiz. Tech team, can we have the results of the practitioner's quiz first? Okay, so this is for the DM quiz. The first prize goes to K. We'll have to clarify who it is. So, K, if you can email us your details, it will be good. The score of 7 out of 10 and with the fastest time. Dr. Abhijit got the second prize with 7 out of 10 score with slightly slower marking. And third prize goes to Dr. Annie, 6 out of 10. So I congratulate all the winners for the DM quiz. Can we have the results for the practitioner's quiz? So the practitioner's quiz, the first prize goes to Dr. Muhammad Tausif. Second prize goes to Dr. S. Rajeswaran. And third prize goes to Dr. Mogalapu Sai Samita. So I congratulate all the quiz winners for both the quiz, the practitioners quiz and the DM quiz. So you will receive a certificate of appreciation from the Indian Thyroid Society. So the DM quiz, the first prize, Mr. K is requested to send an email or contact us regarding your name and details so that we can send the certificate across to you. I thank the quiz master, Dr. Sunitra Mondal, for having conducted the questions and in a very interactive way. Thank you, Dr. Sunitra. I hand over to Dr. Pramila to summarize the session and close the session.
Yeah, thanks, Dr. Vijay Bhaskar Reddy. And it was really a nice quiz session. And we started off with a case presented by Dr. Shruti, and we did discuss about thyroid-associated ophthalmopathy. And Dr. Ankush and Dr. Aditi moderated the session. And then we had a monologue on toxic goiter by Dr. Paul, and followed by the quiz. And I know we all know that quiz is one of the very interesting and sought after session, and Dr. Sunitra conducted it very well. And with this, we come to the end of today's thyroid clinics. And I again request all the winners to please put their mail IDs at least and their names so that we can send you the certificates from the Indian Thyroid Society. So that's very important. The next session of the Indian Thyroid Society webinar is on 14th of May, 2025. That is the second Wednesday. So kindly join us again at 8 o'clock. Please share your research with our journal. That is the Thyroid Research and Practice. You can scan the QR code, and the faculty are invited to become a reviewer with the journal, so that whatever articles are coming, we need more and more faculty to help us to review those articles. So with this, we come to the end of today's thyroid clinics, and I thank all the other coordinators as well, including Dr. Roma and Dr. Reddy for today's session. And if you want to see or you want to watch these sessions, the sessions are available on the ITS website. You can log on to this http://indianthyroidsociety.in, and you can watch these sessions if you have missed any of them. Thank you.
Tasya bhasa sarvamidam vibhati.